and everybody who's online, Zoom-wise as well. Many registrants for sure to the bigger lecture, our annual bigger lecture. This is a very special lecture, and it's the 10th anniversary of the bigger lecture, and it's also the 20th anniversary of the Irving Institute. So this is in celebration and honoring a visionary physician scientist, J. Thomas Bigger, who really performed groundbreaking clinical and translational and basic sciences in cardiology that still continue to have impact in the practice of medicine in a very substantial way. He was a leader in cardiology here, Columbia, nationally and internationally. He was the first division chief of cardiology at Columbia, which would say something in his career spanned 50 years at Columbia, which is an amazing fact. And during that time, he was a true translational physician science in that he did basic cardiac electrophysiology related mechanistic work on drug mechanisms, drug-drug interactions, ventricular fibrillation, and also then studied the effects of ventricular fibrillation on outcomes, and did groundbreaking clinical trials that defined the field and defined medicine in ways. The CAST trial was a trial of therapeutics used for VT that helped us to understand how not to treat patients, and in that sense, is still a hallmark trial and really changed the field. And he was already interested in devices, ICD devices for patients with reduced ejection fraction cardiac function, and manifest that interest in the Cabbage Patch trial for ICDs, which are now the standard of care in that area. Tom worked on areas of heart rate variability. If any of you woke this morning and checked your sleep quality or your heart rate variability, Tom was involved in basic work at the foundation of the relationship of heart rate variability with outcomes and health, as well as things like depression post-myocardial infarction, which are important areas, very important to our patients. And Chuma Wang came and visited us this morning. It was part of, Tom's part of a career where he really got involved in observational data, electronic health record data, which was, again, ahead of his time. So Tom did it all. So in this sense, this is to remind us of the lasting impact of rigorous science and mentorship and a commitment to improving health. And during his career, especially during clinical trials and research, he was heavily involved with communities and patients and getting them involved in the research also. I'll take a moment to also acknowledge that this is the 20th anniversary of the Irving Institute. Henry launched this with Melissa Begg in 2006 at the school and at the medical center, and we're very proud of the impact, and we're celebrating that this year. That has accumulated over 20 years. And we're also very aware of our responsibilities moving forward as the Institute to try and support research, mentorship, training, and our communities and patients and health impact at this very disruptive time. We're proud that we just recently were announced that we received, I think it's the 5th CTSA award at this stage, but a large 7-year award to continue this work. And we have the responsibility to use that very wisely to try and support physician scientists, clinical researchers, and our research community and patients communities at a time of great vulnerability. So we're ready for that and poised for that. Last, I'd like to thank, and in particular thank, the Bigger family. Susan and Angela are here, and the Leahy family. They're very close, and they've been involved in supporting this pair of lectures going back a long time. The Bigger lecture at 10 years and the Leahy lecture going back almost over 2 decades at this stage. And without their support, we would not have had some remarkable celebrations of excellent international speakers in the Bigger lecture series, as well as our local speakers. John Cam, Hugh Watkins, Dan, who's here in the audience, was the second speaker, one of the mentees of Tom back in the day, as well as 2 AHA presidents, one of our own, Mitch Elkind, who spoke here in the last few years, and Katrina Armstrong gave this lecture a few years ago as well. It is worth noting last year we didn't have the lecture because it was a very disrupted time after some of the actions in spring of last year. So in some ways, maybe it was meant to be. The 10th anniversary is the same time as the 20th anniversary of the Institute, and kind of aligns in a way that way. But I want to really thank Susan for being here today, with their daughter Angie, who came in from quite a distance away and came through town when the Knicks were doing their thing last night. So it was kind of interesting, I'm sure, to be here. And also to the Leahy, Fran and Mimi, who were visiting also today. And this allows us the chance to really celebrate the values that Tom really cared about: scientific excellence, mentorship, and discovery. I'm going to hand off now to Henry Ginsberg, who's going to introduce Matt Maurer, or as our speaker today. I could not imagine a more fitting and excellent speaker for the bigger lecture at any point. And we're delighted that he's given the 20th anniversary lecture this year and the 10th anniversary lecture for the bigger lecture. Henry.
Thank you very much, Meredith. And I will be very brief. I heard that Matt has 80 slides. It's an honor to take part in this. And actually, Matt's relationship to me and to many people here goes pre-CTSA, when it was called the General Clinical Research Center, which went back to the 1970s. Neither of us were there at that point. We're also, in a way, 6 degrees of separation, co-alumni, because I graduated from Brooklyn College, and Matt graduated from CUNY in their 7-year bachelor's medical school degree. I was at Brooklyn College before there was a CUNY, and Matt came here in the 90s. And in 1999, by that time, we had met in some fashion, but he was, I won't say ostracized or sent north to the Allen Pavilion. Maybe that's partially correct. But he was setting up a gerontology cardiology service. And I think Mike Weisfeld had a lot to do with that. And we were, I had taken over the GCRC in 94, and we were able to fund him with some infrastructure money to get that going. And from then on, it's just history. Although, having said just history, there are about half a dozen people at Columbia who have been masterful at taking advantage of all the funds of the GCRC and the resources and the CTSA have provided. And Matt has a list that goes on. And so, but he's a wonderful person. He's a wonderful speaker. He'll tell you a wonderful story that he sort of fell into, but has made more than the most of it. And I will just end with one little anecdote. It's something I always remember. There was another Matt Maurer here in oncology, and they used to get confused all the time. And one time I noticed that Matt of today is spelled with 1 T, and the other Matt had 2 T's. And I asked him how that came about, and he said his parents weren't rich enough to put an extra T in his name. So with that, no further ado, I'm waiting for a great lecture from Matt Maurer. Thank you.
Yeah, that's okay. Thanks, Henry. It's a pleasure to be with everyone today. And I guess we have a few slides that we didn't show. We can keep going. Yeah, great. So it's a real honor to be with everyone and give the bigger lecture in the honor of the CTSA. Congrats on the grant. These are my disclosures. The big thing I'm concerned about is the cost of these drugs I'm going to tell you about, which I personally think is ultimately unsustainable. So we heard about Tom. I had the privilege of attending with him. He was my first attending actually in the CCU, and his contributions to the field of cardiology are seminal and many. We still, I think, when we go to the FDA, they have PTSD for the idea of using a surrogate like PVCs to evaluate the efficacy of drugs based on the CAS study. And Dan is here as well, but Dan and Tom were instrumental in my career. This is one of my first papers with them, and I learned a lot. I have to say, they taught me the value of kind of longitudinal continual feedback. They were very rigorous in their expectations of data collection. I remember Tom always said to me, if you write an AIM hypothesis, I'm going to immediately go to the statistics section and see if you can actually test that hypothesis. Probably most importantly, they never made all my questions seem burdensome. And Tom in particular, I would say, offered or avoided, I would say, prescriptive advice. He made you kind of struggle through the process and try to figure out what you were trying to achieve. And it was certainly more challenging, but a lot more rewarding. So very grateful. So today I'm going to outline, I'm going to talk about the importance of the Irving Institute and a little bit of history of TTR biology at Columbia, and then talk about the evolution of this disorder and some research that we have ongoing. So the Institute, I want to remind everyone while we're here, a university is a place where teachers and scholars give and receive instruction, and I think that's really important. And the Irving Institute really serves as a catalyst, as we know, for research, hopefully speeding up discoveries that transform the lives of our patients. And the CTSA has been instrumental in my career. I started this lab called the CCRLE back in 1999, initially, as Henry said, at the Allen. We've moved around, and the main goal was to understand age-related changes in cardiac structure and function and how those could disproportionately lead to the disorders that we see in clinic. And besides Henry and Murdoch, Wahida Karmali helped in my nutritional experiments with Dan when I was studying postprandial hypertension, and statisticians Min Kwang and Shaker. And I've, as you see, leveraged a lot of the resources, including as grateful to Henry for that initial infrastructure grant that helped us launch the lab at the Allen. So this is a disorder, a TTR amyloid, for those who've been following, that has gone from a rare and under-recognized condition to one that I think we're all encountering in clinical practice, one that required endomyocardial biopsy for diagnosis and doesn't anymore, and one that when I started had no treatments and now has a plethora. And so it's been a real transformation. And lest you think it hasn't been, you can just read the New York Times, where earlier last year they talked about this particular condition that's now treatable. This disorder is built upon the idea of misfolded proteins, and I'm still remark at some of these facts that proteins are the most abundant thing we have in the world besides water. Every single protein that we make has to be converted into its appropriate structure in order to do its function, and every protein has 10 to the 16th possible starting configurations. So the fact that we sit here and we make proteins all the time and they don't misfold is really, I think, a testament to evolutionary biology, and that it doesn't go awry more often is amazing. This disorder is due to a small protein, used to be called prealbumin or TTR, that's mainly made in the liver. It's a homotetrameric protein that can dissociate into oligomers or monomers, either because the protein is unstable, as you'll hear in variant disease, or because it gets cleaved and results in deposits in the myocardium that cause the phenotype that we see, which is progressive wall thickening, heart failure, conduction disease, and arrhythmias. This is Bob Canfield, who ran the GCRC, as Henry said. Steve Canfield, his son, and I were chief residents together, but he and colleagues actually sequenced TTR here in Columbia in 1974, and the circles are areas where the protein has variants in it. Maria Saraiva is a postdoc who came from Portugal to work with DeWitt Goodman, and this is back in the 80s at Columbia. They actually described the first variant in TTR, which was affecting individuals typically of Portuguese ancestry, called the Val30Met variant. And now there'll be a test later. There are now over 130 variants in this particular protein that cause the disease that we see in clinic, some of them quite rare. The story of how therapy developed is a testament to these two individuals, Jeff Kelly and Teresa Coelho. Teresa is a famous neurologist in Portugal studying this variant that affects people in their 30s. leads to autonomic dysfunction and neuropathy, wasting, and death within usually a decade or two. And what they discovered was grandparents who didn't have the phenotype, even though they carried the gene, and it was literally 100% penetrant. And so they described and discovered that a second change in the protein at position 119 would lead to a stabilization in the setting of a destabilizing variant. And this idea was further explored by Jeff Kelly, who invented the drug tafamidis, in which you can see here, if you have in tetramer 1, all 4 components having Val30 met, the protein forms amyloid fibrils shown in the black very quickly. And if you add, if you will, restabilizing variants, you can decrease the development of amyloid fibrils. And this led to the idea, could this be druggable? And Jeff discovered that a non-steroidal anti-inflammatory, most common form of Motrin used in Europe, did just that and was effective in humans at stabilizing the protein. And then he went on to essentially make compounds. FX1006A was what is tafamidis, and you can see it's quite similar in structure to diflunisal and thyroxine, which is TTR is a carrier of thyroxine, for those who don't remember, and it fits in the dimer-dimer interface and stabilizes the protein. Another seminal discovery, and Max is in the audience with Bill Blainer, that led to, I think, effective therapies was the TTR knockout mouse developed at Columbia, you can see. And I think Max can tell better than me, but people were expecting that the knockout mouse would potentially die in like literally in utero. But the mice were phenotypically normal. They did have low RBP and TTR levels. And this led to the idea that you could knock out TTR and potentially treat the condition. And I'll talk later, but there are now 3 strategies: small interfering RNA, antisense, and gene editing that all can be used to knock down or lower TTR levels. And we have high hopes for all of them therapeutically. So how has this disease evolved? Well, first and foremost, we've moved from an invasive approach to diagnosis, one in which we had to do a biopsy. This is what we were doing, as you'll see, back in the early 2000s. Endomyocardial biopsy is pretty well tolerated, but it's really limited in its use to centers that have the technical expertise and also the pathological expertise to measure it. And most patients, when you tell them you're going to do a heart biopsy, don't want to run in line to get a heart biopsy. And this is a colleague, Claudio Rapezzi, who unfortunately is no longer with us, but he, in 2005, wrote this seminal paper, I thought, in JACC, in which leveraging bone isotopes, these are isotopes that have been used to do bone scans for decades, you could diagnose TTR amyloid non-invasively. I don't think you need to necessarily be a nuclear cardiologist to see here the uptake of the heart in panels C and D. And this was somewhat isotope specific, in that the patients who had DBT had uptake, but MDP did not. Capitalizing on this work, we actually sought to use DBT in the US, but it's not available, so we use PYP scanning. This is a paper back in 2013, probably the best $200,000 Pfizer ever gave me, because it revolutionized the diagnosis in the US. And you can see here that the patient up top has uptake in their sternum. They have just heart failure, but not amyloid. And the patient on the bottom has clearly got myocardial uptake indicative of the condition. And for those who haven't seen these scans, this is kind of how they're scored. You do a planar image like a chest x-ray. You can see uptake grade 0 just in the sternum with no uptake in the heart. Here's a little bit of uptake in the heart, but less than the sternum. And grade 2 or 3, uptake equal to the sternum or uptake greater than the sternum, is considered positive. And now we do SPECT imaging to make sure that the uptake is myocardial in nature. And so there's now an approach that's been used since 2016 to make this diagnosis non-invasively. You see the phenotype clinically that you suspect in an older adult with increased wall thickness, a syndrome of heart failure. They may be an allele carrier of a gene variant. They can't have light chain amyloid. That's the other major disease you want to exclude. And you can exclude that pretty easily by checking for the presence of a plasma cell dyscrasia in the bloodstream. If there is none, and you order a PYP scan, you've essentially made the diagnosis of TTR amyloid, and then you just need to genotype the patient to find out if they have wild type or variant disease. I highlight this for those who are ordering PYP scans, jokingly, but please don't order the scan without actually assessing for monoclonal proteins, because it doesn't work without that particular step. And these are data that we published because we were concerned about the widespread use and the lack of attention to detail, if you will. So the subject in the upper left is someone who demonstrably has uptake in the heart, but this is someone with AL amyloid, and about 25% of patients with AL amyloid will still have uptake. And these are data from patients ordering the scan at Columbia, where only 40% were essentially ordering the correct blood tests. The upper right is blown up here, but here's a patient who has, you might say, grade 2 uptake. And you can see that this is blood pool. This is inside the chamber of the heart, not in the myocardium. This is another reason for false positive scans. And so we've really improved the diagnosis, and that led to, I think, a huge increase in awareness about this disorder. So light chain amyloid, which I mentioned, highly malignant and a rare disease, is truly rare. There's only about 4,000 new cases a year. The majority have cardiac involvement, but there's no way that this doesn't meet the FDA's definition of a rare disease. There's variant disease, and it turns out 1 in 25 to 30 African Americans, about 3.5% at birth, carry a variant in TTR, people of West African ancestry. And so there are about 1.5 million allele carriers in the US, and depending upon the penetrance of the disease with age, we estimate that there's somewhere between 25 and 120,000 patients affected. So I would argue not so rare. And wild type TTR amyloid, that's the form that affects people as just they get older, no genetic variant, is, I'm convinced, not a rare disease. And so are my colleagues, because about a quarter of patients on autopsy who are over 80 have amyloid deposits. The fastest growing segment of the worldwide population is people over the age of 75. So with this bone scintigraphy, we've done tons of studies, colleagues around the world, and what they've shown, you can see, is in the upper right in HFpEF, about 12% of patients on meta-analysis have amyloid. In mid-range ejection fraction, about 10%. People undergoing carpal tunnel surgery, about 7%. In patients with a phenotype of HCM, it's actually 7, but if you're actually over the age of 65 or 70, it's probably a quarter of patients are misdiagnosed. And I like to always somewhat jokingly say, if you walk on Broadway and you just start scanning and screening people with no symptoms, you'll find about 1% of men and about 0.5% of women over the age of 75 or 80 will have uptake indicative of this condition. So way more common than we ever thought. And there are lots of clues to this particular diagnosis. I think people are very well aware because of the ads on TV about carpal tunnel syndrome. I'll highlight, especially when it's bilateral, but actually carpal tunnel of the spine, if you will, or lumbar spinal stenosis, I'll show you data, is often amyloid. This finding in the office, which is what's called a Popeye sign or a biceps tendon rupture. You just take off someone's shirt and their biceps muscle pumps up. If they have a thick-walled heart, you can look like Dr. House. You don't need to do scintigraphy. They have amyloid pretty accurately, high predictive value. And these are data that were collected actually by, at the time, an undergraduate. She went into med school and now she's an orthopedist. We had the fortune to still do of taking care of her dad, who flies to see us from Hawaii. But she did a study with us in the Cleveland Clinic in which you can see the prevalence in about 1,000 people with amyloid of these orthopedic manifestations. So they are pretty darn common. And we encourage every clinician when they're seeing a patient with cardiomyopathy to take that brief orthopedic history, because as you can see in wild type TTR and in variant, upwards of 90% of the subjects have a clinical history. And these orthopedic manifestations usually precede the diagnosis by somewhere between 5 and 15 years, though that's not always the case. And we see lots of patients now being referred in as people are trying to identify people with the phenotype. These are data that suggest that this approach might be useful. We did this study in Denmark, where they have a national health service, and we found about 1,100 patients who had bilateral carpal tunnel syndrome 5 or 15 years ago. We didn't tissue type it. We didn't look for amyloid. They just had that clinical syndrome. And we invited 125 men and women in. And the bottom line is only about 6 or 8% had disease. But if you're a man over the age of 70 and you're not obese, it was 1 in 5 had demonstrable uptake in the heart. And these are people who had early disease who would significantly benefit from disease-modifying therapy. The spinal stenosis story was started actually at the Allen, because we have a big spine hospital up there. And we did this study with support on R21 from the NIA, in which we show that 1/3 of patients with undergoing clinically indicated spine surgery have amyloid. And it's more often TTR as the precursor protein as people get older. And that led to an R01, which we're currently doing with 5 centers, in which we're taking spinal specimens, shipping them off, and people had spine surgery to the Mayo Clinic, and inviting those people in who have amyloid to get tested. And those data, this is preliminary, are shown here. The high level thing is almost half of the patients have amyloid in their spine. And this is not just a trace amount of amyloid, it's enough that we think it could demonstrably be important. For those of you who don't know, this is Fabrizio Ramati in our pathology department, who's been a co-investigator on this R01. And as you can see, more often in older adults and men is the amyloid burden higher. So a lot of awareness, I think, about the disease, but what really tipped the apple cart over, I think, was the advent of very effective therapies for this particular disorder. And as you heard, there was some important basic biology conducted by Jeff Kelly that led to the development of the drug tafamidis, which we began to try to start to test. And so this is kind of a summary of where we're at this point. There are three main strategies, we think, to try to address this condition. There is, in the middle, stabilizer treatment, tafamidis, or a new kid on the block, acoramidis. These are small molecules that, as you can see in yellow, fit in the dimer-dimer interface and stabilize the protein. So they prevent the protein from breaking apart and forming monomers, and therefore you stop the amyloid cascade. There is ways to silence the protein production, either siRNA or antisense or potentially gene editing. And then the pie in the sky, and hopefully something we won't need that much in the future as we diagnose people earlier, is monoclonal antibodies that can activate the immune system and maybe engage macrophages to remove the amyloid from the affected organs. So this was the study I had the privilege of co-leading with Claudio Rapezzi that kind of pushed off the field and was published in the New England Journal in 2018, this drug tafamidis. And so we studied about 400 patients, a relatively small trial size. You can see here, patients were given either 80 milligrams or 20 milligrams of tafamidis, which was pooled and compared to the placebo group, mainly older adults, predominantly men, 91%, and predominantly wild type, though about a quarter had variant disease. These are patients who have preserved ejection fractions, very thick-walled hearts, pretty elevated biomarkers. And I just point out their stroke volumes are 45 mLs. That means if you index it to their body size, these people are in subclinical cardiogenic shock all the time walking around. But they only on average complain of NYHA class 2 symptoms. So I think the good news about this disease is it's not rapidly progressive like light chain amyloid. And we have an opportunity really to identify people earlier and intervene. We were totally surprised by these results. This is a trial in which we use a novel statistical approach, which we could talk about, called the Finkelstein-Schoenfeld method, kind of a hierarchical endpoint in which every patient on drug is compared to every patient on placebo in a pairwise fashion, and you get what's called the win ratio, and the win ratio is highly significant at 1.695, and you can see the p-value. But probably the most important thing was that the absolute reduction in mortality, not relative risk, but absolute, was 13%, which is not something we usually see with drug therapies. We didn't plan just to use Kaplan-Meier analysis, but I've gone around talking about this trial for 7 or 10 years. No one knows what Finkelstein-Schoenfeld is. And in the New England Journal, besides presenting the primary endpoint, we showed that the drug was associated, quite surprisingly, using traditional statistical models with a 30% reduction in mortality. And that was even better when you took out the patients who we assumed, quote unquote, died, who got a heart transplant or an LVAD, which were very few. And probably the most important thing that we initially learned from this trial, besides having an effective drug, was that despite it meeting all the pre-specified endpoints in the subgroups, there was one subgroup in which the drug prolonged life. That was patients with NYHA class 3, but they lived in a state in which they spent actually more time in the hospital. We can certainly debate about whether that's a good or bad thing, but this led to the idea, which is shown in this slide from the trial, that if you had NYHA class 1 disease, and I can tell you out of 441 patients in this trial, only 37, so very few, less than 10% had NYHA class 1, they did, though just look at the point estimates. I understand the confidence intervals are wide, but there was a much lower reduction in mortality and in clinical events when you had earlier disease. And this has really spurred on our whole approach in trying to actively ascertain this condition. I would point out that in this particular realm, colleagues at Columbia recently published these data. This is Pierre Elias, who runs the AI program in cardiology, and Tim Porteruca. They did a trial in which, using electrocardiograms that were trained on patients who had amyloid versus not, they found a signal, and they essentially called those patients in who they could touch, and you can see that the yield was 50%. So 1 out of 2 patients they called in to get tested actually had disease, which was much higher than the traditional group. The downside of this approach in the if you will, concert diagram, as they call it, 250 people and only 50 agreed to come in. And so we have an implementation science approach that's needed. Many patients, if you call them and they don't know who you are and tell them you might have a rare life-threatening disease, they're apt to hang up the phone and not want to talk to you much longer. And so we have a lot of cool techniques, but how we utilize them is going to be important. I just point out here that, I brought on faculty by Milt Packer and he wanted me to study HFpEF. I ended up in amyloid. At the time, he didn't think it was a good idea. Now I think he agrees it was fine. But these are data from large clinical trials, and you can see the number of patients being recruited in those trials, none of which showed a reduction in all-cause mortality. And you can see here that the ATTRACT trial with 441 patients kind of has led to pharma and other people really focusing on this idea of precision medicine and getting a huge big bang out of a therapy. These are data that we published from our center back in 2001 to 2013. People would say I wasn't generating a lot of RVUs. I only saw 101 people with amyloid. More recently, in this decade, we saw 215, and now we see 250 new patients a year with amyloid. And you can see everyone needed a biopsy years ago, and now very few people need a biopsy. In gray is a Columbia staging system that we developed. This is advanced disease. Very few people have advanced disease, and people are getting disease-modifying therapy. So earlier diagnosis and disease-modifying therapy has led to tremendous improvements in survival. So these are the data when I started the program back in 2004 to 2013, and you can see that the mortality was about 50% at 2.5 years, and now mortality isn't even reached at 5 years, and is probably a condition that people might live with and never die from if we find them early enough. The next kid on the block was acoramidis, another agent that we studied and that was published in the New England Journal using a similar approach. It's a stabilizer. It tends to capitalize on this T119M variant, so it binds to a different spot in TTR, and there's a lot of debate about whether it's really a better stabilizer, but it works as well, and certainly no worse. And you can see one interesting phenomenon that happens when you give people a stabilizer is their serum TTR levels increase. And so that's something we use in clinic to demonstrate to patients that the drug's actually working, because they often say, this drug has no side effects. How do I know it's really effective? This trial also showed benefits, though not statistically, on mortality in the original trial, and that's because we found people much earlier and mortality was much lower, but it did have effects on 6-minute hall walk distance and morbidity. And in longer term extensions that we published, you can see there was a mortality benefit, just took longer to realize. And the decrement in mortality and cardiovascular hospitalizations was 50%, reflective of the fact that we're finding people at a better time to administer these drugs. So the next strategy that I mentioned, capitalizing on the work that Max and Bill Blainer did about knocking down TTR, comes from other amyloid diseases. So AA amyloid is a disorder of chronic inflammation. We don't see it very much anymore, but it's seen in third world countries. And the lower the precursor protein, this is serum amyloid A, the better patients do. And in light chain amyloid, I see Raj here, one of my colleagues in hematology, the whole goal is to shut off the plasma cells and stop them from making the bad monoclonal protein. And you can see here in patients who have what we call a complete hematological response, they do much better. So shutting off the precursor protein seems to make sense. And so we have drugs now that do that. And this is the next agent that was approved last April. It's called vutrisiran, a small interfering RNA that's sub-Q administered in the clinic every 3 months. And basically, across 10 pre-specified endpoints, mortality, cardiovascular hospitalizations, function, the drug was highly effective. Not only in the overall population, which included about 40% of people concomitantly taking tafamidis at baseline, but in the so-called monotherapy group. And so a highly effective therapy. These are the Kaplan-Meier curves from that study, looking again at death in the overall and the monotherapy population. And this also prolonged life and prevented death, thank goodness. So we have, I think, as I said, a relatively short period of time kind of transformed this field. And now we're struggling with a lot of emerging questions that I'll try to describe for you. So we have 3 agents. Which one should we pick? We don't know. Should we combine them? Should we deprescribe certain agents? Is there ever a time to stop therapy? There's a huge financial burden that we need to address, and we don't really have head-to-head data. So the companies are out there kind of marketing up the wazoo, I would say, with no clear real data to drive decision making. This hopefully will answer some questions. I'm the chair of the steering committee for this. This is the largest trial in this space. It's using a drug called aplenotersen, which is an antisense that silences TTR. This is a trial of 1,400 patients, 1,432 to be exact, that has fully enrolled, and we're going to unblind and unlock the database in about 2 weeks. So we'll learn. Probably most important in the hierarchy of the secondary endpoints is people are most interested in, will a silencer help on top of a stabilizer? And we'll have about 1,000 patients in this trial who are on stabilizer therapy as well. So that'll be important. Gene editing has been talked about, but it's actually being done in amyloid heart disease. These are data from Julian Gilmore at the NAC in London. This is an approach in which a lipid nanoparticle is laden with a TTR-specific guide that brings the CRISPR scissor to chromosome 18 on a hepatocyte and essentially cuts the gene at that spot. And you can see serum TTR after one infusion lasting about 3 or 4 hours is knocked out permanently and for forever with very low variability. And in this small trial, open label, 36 patients, these had patients who were pretty advanced. The patients were pretty darn stable with regard to cardiac biomarkers, 6-minute hall walking KCCQ, which is not what we typically see in this particular population. And these are data demonstrating using MRI, global longitudinal strain, and extracellular volume that there are patients with this approach that seem to be having less amyloid inside the heart and improving. We raised the idea that could this one day be a cure for this particular condition, especially, God forbid, if you're a carrier of a gene and you unfortunately watched your parent, pass away from this, you're going to be quite motivated to address it early, and we'll see if that's the case. So I'm co-chairing with Julian international phase 3 trial called Magnitude, which is investigating whether or not gene editing will demonstrably improve outcomes for these patients. It was going really, really well until last September when 4 patients had liver toxicity. The trial appropriately was put on pause. We've investigated extensively. We think we have a mitigation strategy, and now the trial has been reopened. I can tell you more about that, but we're actively recruiting. The field has evolved so much that now there are what we call concise clinical guidance documents by the American College of Cardiology. In the middle here, they talk about who should get which therapy, and the conclusion is, we don't know, pick a therapy if you have the disease, don't get too fixated on which one. And they discourage combination therapy at this point. For those of you who don't know, that would cost about $900,000 or $1 million per patient per year. And so without any evidence, not a great thing. There are patients who are probably too early for disease-modifying treatment. We'll talk about them. And there are patients who are likely too late. So these are the too early patients. I mentioned these allele carriers, right? They're at risk for having a disease. And if they're within 10 years of the disease onset of their relatives, they're quite panicked and worried. And Eugene Berlovsky in our group is heading up this trial called ACT Early, in which acoramidis, the stabilizer I mentioned next in class, is being used as a prevention to prevent the development of disease. And we're excited about this. Our former faculty and fellow, Adam Castano, is heading up this trial by the pharmaceutical company. And there are people, unfortunately, thankfully, you can see here in this list of a large number of patients, 6 at the bottom in purple, but who have very advanced heart failure and come very late. And no matter what we do, they have a very high mortality in a short period of time. And there's a debate whether they should even get disease-modifying therapy. So in the search for earlier detection, obviously one thing someone might ask is, can you develop a blood test to detect this? And this is an active R01 we have with Lorena Solissis. She's a structural biologist at UT Southwestern. You can see up here is the amyloid cascade. Years ago, we looked for low voltage or clinical symptoms. Now we do nuclear scintigraphy or biopsies or maybe PET scans. But this is something called TAD1, Transthyretin Amyloid Detector 1, that Lorena discovered and developed. She took amyloid deposits, examined them by cryo-EM, and found similar structures and developed a protein peptide that binds to a common, if you will, loop on all the amyloid fibrils shown here. And she published data that suggests that it can diagnose the condition from a blood test. And we're testing that in a large screening study that we completed with NIH funding called ScanNP. So we'll see, but that would be quite exciting. A second issue is that people believe that the biology of this disease is always related to misfolding of the TTR protein and that it's unstable. So samples from SCAN-NP on people who had disease were matched to those who did not. And this is an assay that Jeff Kelly developed to measure the stability of TTR. And I think you can see that TTR is no less stable in patients with age-related, non-genetic wild-type disease than those who are age-matched controls, implying potentially that everyone's TTR might be falling apart as we get older and there could be other mechanisms. So while everyone was focused on proteostasis and protein misfolding, we would submit that cellular senescence may be a mechanism, the body's inability of the immune system to handle misfolded proteins and take care of them. And so this is Rick Ruberg, who co-led the SCAN-NP study with me. We've had an active collaboration for years. He's chief of cardiology at BU. I didn't highlight it very much, but a majority of patients that we see with wild-type TTR amyloid, and I don't mean a minor majority, I mean like 85% of the patients are men. Kind of, are we missing it in women? Probably. But this was an observation we had for a long time. And for those of you who don't know, Ken Walsh, who's the second to last author in this paper, he's a biologist, used to be in Boston, but now is at UVA. And he had developed a mouse model of what we call loss of Y. So as we age, we lose our Y chromosome. Those of you over 50 or 60, it's disintegrating while you're sitting here. And that mouse model that didn't have a Y chromosome had a lot of deposits in various organs and seems to be subject to this immune senescence idea. So in this preliminary data that's now supported by an R01, we showed that loss of Y was higher in TTR wild-type patients than HFpEF, and that the more loss of Y you had, the greater the risk of all-cause mortality. And so the hypothesis we're going on is that there's something on the Y chromosome that's going to help with misfolded proteins, and losing that is part of the problem. We're working with colleagues to measure loss of Y in extracellular volume, for example, on MRI, to see if it correlates with the phenotype. So quite exciting work, I think. The final strategy, which is still pie in the sky, but a lot of efforts, is this idea, could you reverse amyloid? So for those of you who don't know, you can, the classic paradigm by Doug Mann shown here is you get a heart attack, your heart remodels, you get a low ejection fraction, might need a defibrillator, but you can use drugs to compensate and reverse remodel the ventricle. And the question is, could we do the same with amyloid heart disease? So these are data that Mariana Fontana published in the New England Journal of 3 cases of patients at the National Amyloid Center in London who spontaneously just got better with nothing, no treatment at all. And none of the more than 1,500 controls had that. And as you can see, here's a patient where the voltage gets better, the strain is improving. Here's their scintigraphy. Heart has amyloid, now heart doesn't have amyloid. The Doppler signal's improved and the walls on the echo are less thick. And all of these patients had polyclonal antibodies to TTR that they developed on their own. At the same time, there have been a whole group of interest in antibodies, both for AL and TTR. And I can't not highlight the work of Suzanne Lynch, who's here with us. She was instrumental in developing this drug, anselinimab, which is a monoclonal antibody for AL amyloid. Interestingly, it was developed in mice for kappa AL amyloid. The study that was done was for all forms amyloid, and it was neutral. But there was, you can see, an effect on all-cause mortality and cardiovascular hospitalizations in the kappa subgroup. This has led a lot of us to start to believe in this approach. And there are several ongoing clinical trials. So this is a drug, coramitug, again, a monoclonal humanized antibody that binds to misfolded TTR and essentially, again, activates macrophages and allows them to hopefully remove amyloid from various organs. And this is another drug called cliramitug. Good luck remembering the difference. But these are data by a colleague, Pablo Garcia Pavia in Spain, that he published exactly at the time that Mariana had described those 3 cases in the New England Journal. And this is an antibody, again, now called cliramitug, but made by Neurimmune, in which you can see here's a subject who was getting the antibody, and after 4 months, the uptake in the heart is much better. Here's a subject who unfortunately was randomized to placebo for the first 4 months, but then transitioned over. And there was not only scintigraphy, but MRI evidence of improvements. And those are shown here, in which this is a graph of the increasing exposure of the antibody over time and how much scintigraphy and MRI improved. These were dramatic improvements in MRIs. I mean, MRIs that had extracellular volume, normal is like 25 or 30. These people had like 55, and they would go down by 20 points and bring the heart back to what was a normal amount of extracellular volume, presumably removing amyloid. So this is in a trial. The good news is patients are really enthused about this trial, and this trial was fully enrolled 14 months faster than anyone ever expected. We have more than 1,100 patients in this trial, and sitting on the steering committee, we're anxious to see what this shows. Another drug that I mentioned previously, coramitug, this is a phase 2 trial that we published just recently and presented at the AHA. This is a trial in about 104 patients randomized to placebo, low or high dose of coramitug, 10 milligrams per kilo or 60. And all of these patients were on disease-modifying therapies. They all took a stabilizer or a silencer. And you can see that the NT-proBNP was reduced by about 48% in patients who were on the highest dose of the drug, with some significant differences in echocardiographic parameters. And so my lab is vigorously helping to enroll folks now in this trial, which again, I'm co-chairing with Mariana, sponsored by Novo Nordisk, but this is an antibody trial, again, trying to remove amyloid from the heart and see if we can improve outcomes. Finally, I just point out that I think we may have a problem with our current diagnostic standard. So this is the seminal article that Julian published. I had the privilege of being co-author. He dragged us all to London for a great trip. We sat in a room and we tried to come up with the algorithm that we now use. And these were 1,200 patients, 350 of whom had concomitant biopsies. And the data has been, seminal in changing the field for early diagnosis. But patients had pretty advanced phenotypes, and we're seen at amyloid centers. And while the specificity was very high, so if I do scintigraphy and there's uptake and the monoclonal proteins are normal, and I tell you have amyloid, I'm certain you have amyloid. But the sensitivity, I would argue, is not that great. And this is in a population who has advanced disease. So could we be telling people you don't have amyloid when they actually do? And these are data that we work with Andrew and Dia Smiley, one of our amyloid fellows, worked on. We published recently. But this is a PET scanning agent. I'll tell you more about it in a moment, called evuzametide. But here's a subject who carries the variant that affects African Americans. His brother has disease and he wants scintigraphy. So we do it. And there's really no uptake really in his heart area. This is what we call SPECT imaging. The uptake you see here is in the sternum, so there's no cardiac uptake. And this is probably easy to interpret. This is the SPECT CT of the PYP, and there's nothing going on. But the same patient, when he gets an evuzametide PET scan, has demonstrable uptake in his heart that we didn't see with pyrophosphate. And I would point out the bone agents, we've never really known how they work. We don't have a mechanism, so it's a little unsatisfying. And in this small pilot trial that we did, there were 18 patients who basically were allele carriers, and a majority of them were PYP negative, but actually evuzametide positive. We could detect earlier disease. And excitingly, this has now been studied in a trial that we'll hopefully report out very soon, the details of, but the high level is the trial worked and the diagnostic worked. So this is an agent called evuzametide. It's a small peptide, 19 amino acids, that Jonathan Wall in Knoxville, Tennessee developed. And it has a lot of lysine charges. And it turns out that amyloid deposits have a lot of negative charges, and lysine charges bind to where the amyloid is. And then he labeled it with I-124. And so in this upfront trial for diagnosis called REVEAL, the trial met its primary endpoint for sensitivity and specificity. And so we're hopeful that this could be a new diagnostic that we utilize, especially for those patients, for example, with carpal tunnel syndrome or carriers who really want to be identified earlier. We'll see what the FDA says when we submit the data. So I can't thank everyone enough for all the support over the years. I would say that there's no doubt that the Irving Institute has been essential not only in my career development, not only the funds, but really the people, Dan, Murdoch, Henry, and everyone else, and certainly in leveraging those resources. I remember Tom fondly, and very pleased to be able to deliver a lecture in his honor. I can remember when I was a first day resident in the CCU, I was kind of trembling with my paper trying to present to him. And he grabbed my paper away and he said, just tell me what you remember. That's all that's important. We'll help you fill in the rest. So that was really nice. I think the field of amyloid is really exemplary of what precision medicine can do. we've radically changed the diagnostic and therapeutic landscape for patients. And that's a collaborative effort amongst really amazing, brilliant basic scientists who set the groundwork, delineating what the mechanism of the disease was, and then the collaboration amongst clinicians, trialists, most importantly, the patients and their families, that led to these high quality late phase investigations. And I think the future for these patients is really quite bright. So I'm happy to take any questions. And I think I left 10 minutes despite 80 slides. Oh, sorry, I can't not but thank the innumerable people on the left in my laboratory, fellows, research assistants, the managers, and obviously the clinical team who sees lots of these patients who are here. So very, very grateful for all your support. Happy to take any questions. Max? Yeah, good question. It did a few years ago. So Max asked, does the variant or mutation dictate the therapy? We used to dichotomize patients into those who had variant disease with neuropathy, and the studies were done initially with silencers, and they preferentially got those. The phenotype, I'd say more right now, probably dictates the condition. We do believe the silencers might be slightly better therapies. We don't have head-to-head than the stabilizers for patients with neuropathy than cardiomyopathy. And so many of the variant patients have a very prominent neuropathy. And so they preferentially would get a silencer clinically as opposed to a stabilizer. Whether patients with age-related or wild-type disease actually have a neuropathy, I defer to my expert colleague, Dr. Brannigan in the back, who helps me manage a lot of these folks. But our sense is that it's not completely clear. I don't know if you agree, Tom. Yeah. Yeah. Tom's done some really important work looking. A lot of their complaints of lower extremity discomfort are due to lumbar spinal stenosis, not necessarily a true neuropathy. Henry?
Decades ago, idiotypic antibodies were identified, but we all have antibodies.
Yep.
Or a natural protein. There's 3 people. Is there anything special about that variant, or you find many more people with polyclonal antibodies?
They're pretty rare. As you can see, it was 3 out of like 1,663. One of them had the Val122 ILE variant that affects African Americans. 2 other were wild type. I don't know that anyone's actually figured out. They weren't particularly young. That was one hypothesis. Certainly patients with, a light chain amyloid that were able to shut off the production from the plasma cell, they can actually spontaneously get a lot better. But my experience is they get better if they're like under 55. But to be determined, the hope is that these monoclonal antibodies will be effective. I'll be clear, I'm taking care of 10 or 15 people in the Irving Institute, thank you, on the long stay unit who are coming every month to get infusions. They may be doing a little better, but they're not jumping up and down. It's not a dramatic effect yet. So we'll have to see what the outcome studies show.
Matt, wonderful. So I think there's 2 areas. One is that I want to ask about. One is the antibody and clearance pathways. And you'd suggested there's later stage disease that may not be responsive to the silencers and the stabilizers. Have you evidence yet that the antibodies can be effective in very late stage disease or late stage disease? And is that where some of the trials are pointed at?
Yeah, the latter. We don't have evidence, but the companies have all gone all in and decided that, I hope appropriately, but I'm not sure, with good signs that, later stage disease. So one trial we have actually has enrolled patients who were sicker than the original tafamidis trial on average. I hope they're right in that decision making. Everything we know about the other 2 therapies, stabilizers and silencers, is earlier is better. Here, the trials are recruiting pretty sick people, but we'll have to see. I think we'll learn through the trials.
And the other question is on the wild type side, which is pretty interesting that there's not much difference between wild type and non-wild, or wild type disease and wild type non-disease in some of this.
And the stability of the protein, which is the prevailing paradigm, it's not less stable. So,
and then
it's a good theory, but
then you kind of move towards the aging and the Y chromosome side of things. But what are the kind of things that are in your mind or in the field's mind around the potential mechanisms that would?
Oh, I definitely think there's a disorder as we age of not handling misfolded proteins. I would analogous this to not exactly maybe prostate cancer where PSA goes up. And this is, I think everyone's TTR falls apart as they get older. I bet the younger patients have more stable. We haven't done that, but the age match controls were not less. So I think TTR is an unstable protein that is very amyloidogenic. Why is it amyloidogenic? It has a lot of beta-pleated sheets, so it easily stacks on each other. And I do believe that for the wild type disease, the big combination, if antibodies are effective, is going to be that, is something to reverse the disease or stabilize it, and then continue them on maybe combination treatment with the two agents, one that might be oral and stabilize, and one that would handle misfolded proteins.
And I guess preventive end of it is like, is there any observational, epidemiological, or longitudinal data suggests that any lifestyle or other types of activities can change whether people would be?
Yeah, the only observation we've made, and I'm not sure this is causal, and I always am cautious about, is that a lot of athletes seem to have this. People who are highly physically fit, you might argue that's related to cleavage of the protein. There's definitely, whether those people really have more disease or they just tend to be athletes and notice their decrement and come sooner, no one's too sure. Interestingly, the association, I didn't highlight it, with aortic stenosis is quite high. So we did a paper years ago showing that with our TAVR group, that 16% of patients overall and upwards of 22% of men undergoing a TAVR had amyloid in their heart. And that may be due to potentially some shear forces that are, structurally, disrupting the structure of the protein, but that's theory, not proven. Dan?
Yeah, Matt. So what's known, apropos my meeting with Brian earlier, what's known about the rate of AFib or stroke in these patients?
Yeah, so AFib is very, very common. Essentially, all series, no less than a third and upwards of 70% of people at presentation could have atrial fibrillation, so the two come together. We anticoagulate these patients irrespective of their CHADS VAS score, so they're very high risk. And when they're on an anticoagulant, we don't stop it, even if they go back in sinus rhythm. Brian, one of our fellows, is working on this observation that there is a phenomenon called atrial electrical mechanical dissociation. So the EKG is sinus rhythm, and the atrium is not really moving. It's supposed to be moving like this. In AFib, it's moving like this, and these people aren't moving. That's probably due to a lot of amyloid infiltration. Those patients have stroke rates of like 10% per year, quite high. And we think that in the realm of prevention, and maybe the drugs that you're working on, factor 10A inhibitors might be really helpful in that regard to prevent strokes. Having said all that, they're pretty older adults who are frail, so the bleeding risk. So that's where the agents you're working on could be potentially perfect in this arena. Yeah, stroke's devastating to these folks.
What about the bleeding risk from the anticoagulants? Is it different than the general population of AFib patients?
Yeah, no, I mean, we did small studies. I mean, no one's using Coumadin much anymore, but the bleeding risk was similar. There's data to suggest that they do have a lot of, cutaneous bleeding and other bleeds, like anyone whose, average age is 80. So, better anticoagulants would be very, very helpful in this particular distinct population, who I think is kind of a model for the rest of the group, in that amyloid is very thrombogenic. And so if we can show that it works in this group with a high event rate, it could be something that we think about for other individuals who just have an atrial cardiomyopathy and not amyloid heart disease. Oh, Raj, sorry.
For the efusatimide data that you showed, is it able to also identify AL amyloid or only TTR?
Both. So everyone who was included in the trial, you'll hear more details about it, but it was a trial of about 170 patients, and 20 or 25 had AL, and the data looks equally good. The efusamitide PET scan is not specific for the type of amyloid. So we'll image amyloid anywhere in the body, gelsolin, ApoA4, TTR, and AL. Thankfully, they'll need you to figure out what type it is. But it's a way to get really quickly a diagnosis early, and judge which organs are affected and what's going on. So very exciting.
I had one more question. For the CRISPR study that you showed, that there is almost like a 90 to 100% decrease in TTR protein level, but then the NT-proBNP stayed flat. So in AL amyloid, for example, we would expect the NT-proBNP to go down if there is a 100% decrease in light chain. Is there like a difference in biology between the different amyloid proteins?
I mean, AL, as you know, is I'd say not just an infiltrative cardiomyopathy, but it's toxic to cardiomyocytes. So it's the most malignant form of amyloid we see, and what we're always interested in diagnosing as quickly and early as possible. I don't think TTR has that much toxicity to cardiomyocytes, so we're pretty content when we can keep things stable. And the natural history on stabilizers and silencers is despite therapy, it still goes up. And so we'll see, this is not comparative data, it's just open label, but the fact that 36 patients, half of which had NYHA class 3, were stable out to 3 years, my hat's off to my colleagues in London. Looks pretty good.
Matt, thank you for that wonderful talk. I was struck by the variant in African Americans, 4%. That's a pretty high number, and it made me wonder about the type of public health efforts around that number, given the rate of hypertension, how common hypertensive heart disease is, and the delayed diagnosis that might lead to. What type of efforts are being done there?
Yeah, it's a great question. So as you point out, it's pretty common. And if you multiply the number of African Americans in the US by that percentage, you get 1.5 million carriers, right? And there's data in JAMA, Scott Solomon, others published that there's probably 1 million years of lost life due to this particular variant and late diagnosis. The SCAN-NP study we had stood for screening for cardiac amyloid with nuclear imaging in minority populations. So we enrolled 650 self-identified Blacks or Caribbean Hispanics. And we found out that in African Americans, about 7% who were undiagnosed, who had heart failure, had amyloid. And if you were a male over 75, it was like 20%. So to your point, we need help with implementation science, folks. The other thing that's a tragedy is the variant is inherited in autosomal dominant fashion. If we have individuals who carry another variant, it's called ALA60. Murdoch's sister helped describe it, Mary Riley. It's in Irish individuals. Every single family member there gets tested. If we try to do the same thing for some reason in African Americans, trust, other impediments, we have very, very low rates of testing. And that's a shame because it's 1 in 2 who might carry the gene, and we could identify people earlier. We had written several grants to try to address that, but they didn't get past the funding line. But I do think that's a whole area that we really do need to focus on. And the variant in African Americans is a little bit like AL in that those patients do considerably worse. So we should really up our game in trying to identify individuals. We worked heavily with Harlem Hospital and Damian Currian in the SCAN-NP study and have identified quite a few people, but it's really an area that needs important work. And I'm grateful for you pointing it out. Hi.
Just for gene therapy, were there a lot of target effects, like splicing at different parts of the genome?
Yeah, great question. No, that we know of. Obviously, the fact that they had 4 cases of LFT abnormalities that were pretty serious raises questions. It's interesting that LFT abnormality did not occur in the first 2 to 3 weeks after the infusion and the drug is out. What we think is happening is there may be a little bit of a new peptide being formed where you cut, and there's then a immune response to that peptide. And I can't tell you all the details, but there may be certain immunophenotypes that are at risk for this. And so we may be able to predict who's going to develop it and then say to them, you know what, I know you're interested in gene editing, but that's not the greatest idea. Just take a drug that does the same thing, albeit repeatedly. But the drug-induced liver injury, which we think is, again, inflammatory and is responsive to steroids. So the FDA did allow us to reopen the trial with some mitigation strategies. And I can tell you the sponsor is really hoping they work, because if they don't, gene editing for amyloid will be, it's a very difficult field. My own comment about gene editing is it's literally one SAE from being away from being done, right? People don't tolerate, big errors like they do in pharmacology for some reason.
One last question, Henry, to close us out, and then we'll just summarize.
Yeah, several recent years, big databases have said that if your HDL is very high, it's increased cardiovascular mortality.
HDL high.
HDL. There's now a U-shaped curve that's worrying everybody.
And
I was just wondering, and you mentioned A5, but A1, there was an A1 variant demonstrated 40, 50 years ago that had amyloid associated with it. And I just wonder if these people with very high HDLs may be dying of amyloid heart disease. It's the UK Biobank and another 1 million people.
Yeah.
Might be something to look at.
Could be. I mean, I can tell you that if you're lucky enough to get to 90 and you're a man, it's 50-50 that you have amyloid. I mean, it's really pretty common. So I think it's something that when you're taking care of octogenarians and nonagenarians, you really need to kind of put on your differential. The only way to diagnose the disease is think about it. So hopefully, if nothing else, you'll leave here thinking, does the next patient I'm seeing in clinic potentially meet this phenotype and, you know, save a life by making an early diagnosis? Thanks again for your attention.
With that, I just want to thank everybody here and online on the Zoom. What a fantastic lecture. You know, it demonstrates therapeutics across the spectrum. This disorder has allowed us to understand more about general therapeutics and antibodies and gene therapy now, where we're, you know, you're beginning to see some of the challenges. And then small molecule developments. Can we use a non-steroidal here? I always ask Matt, well, what's the problem? Which is usually, well, save a lot of money, but delivering the therapeutics to patients, big challenge Matt has spoken about, and then screening for the disorder is just like, we should be able to do better. So much here is unknown, you know, a couple of decades ago, and just revealed through the kind of work that Matt has exemplified and that Tom sponsored and really drove forward. And you can see so many connected things happen at Columbia with mouse models and biochemistry and structure and other areas. So a fantastic legacy. I want to thank Susan for being here, Anja for being here, and the Lee family, and for their sponsorship and support. These lectures really are models for translational science and research that have impact in patients and in healthcare, and disseminating the work and sharing the work is critically important. So thank you for support. And with that, we'll retire, but thank you so much to everybody for being here. Oh, and thank you to Freddie and the organizers who helped get us all together today. Did a great job.